Good afternoon, everybody, and welcome to this ERKNet webinar. My name is Elena Levchenko. I'm a pediatric nephrologist from Amsterdam, and I will moderate this session for you today. Before starting, let me remind you that your microphones are turned off, but that during and after the webinar, you can send your questions through the GoToWebinar application that appears on your screen. So please ask your questions and be active. I will ask your questions at the end of the webinar. It will last approximately 30 minutes, and we will have about 15 minutes available for questions. Our speaker today is Professor Pascal Houillier. Pascal Houillier is a professor of physiology at the Université Paris-Cité in France. He previously held the position of professor of physiology at the Pierre Marie Curie University. He was trained in Paris, and his clinical interests really lie mainly in the fields of diagnosis and management of mineral and electrolyte disorders and management of chronic kidney disease. He is a coordinator of the Reference Center for Rare Diseases on calcium and phosphate in Paris. Pascal, his research activities include pathophysiology and genetics of inherited tubular dysfunction, as well as physiology and hormonal control of renal tubular electrolyte transport. Pascal published a lot of papers on renal physiology, pathophysiology, and tubular disorders. And as you can see, the title of the lecture of today is Disorders of Renal Calcium Handling. Please, Pascal, the floor is yours, and I'm looking forward to hear your lecture. Thank you.
Thank you very much for the very kind introduction, and good afternoon, everybody. And I'm very pleased to be here. And as you understood, I'm a physiologist and a physician, and my presentation will be very much physiology oriented. As an introduction, let's discuss a case. This is a 4-year-old boy who were admitted to the emergency room because of seizures. Plasma calcium was measured very low. Plasma magnesium was normal at that time, and plasma PTH measured because of hypocalcemia was normal but inappropriate. Estimated GFR was normal, and urinary calcium was measured and was considered as normal. And my first question is, which one is the most likely diagnosis? Is it most likely hypoparathyroidism? Is it most likely vitamin D dependent rickets? Or is it most likely pseudo-hypoparathyroidism type 1?
So I opened the poll and we wait another 20 seconds. Okay, 5 more seconds. Can you see the result?
Yes. So almost 50% picked hypoparathyroidism, and this is the right answer. Because vitamin D dependent rickets and pseudo-hypoparathyroidism can cause hypocalcemia, but they are associated with high PTH, not normal or low PTH. So the only diagnosis that matched was hypoparathyroidism. So the diagnosis of hypoparathyroidism was made, and it was treated by alpha-calcidol and calcium carbonate for years. I've seen him, I'm not a pediatrician, I'm an adult physician. When he was 22, he was on alpha-calcidol and calcium carbonate for 18 years. He still had episodes of tetany, plasma calcium was still low, plasma magnesium was normal, urinary calcium was 10 millimole per day, eGFR was low, and he had nephrocalcinosis and no renal wasting syndrome. And at that time, because urinary calcium was very high regarding the hypocalcemia, we investigated whether a genetic cause could be present, and we found a point mutation in the calcium sensing receptor, and the conclusion was that they had a specific hypoparathyroidism that's named autosomal dominant hypocalcemia due to activity mutation the calcium sensing receptor. He has been treated by a recombinant human PTH and is fine ever since. So the outline of my talk will be to highlight the role of calcium reabsorption in the kidney in calcium homeostasis, to describe the mechanisms and factors that are involved in calcium reabsorption in the kidney, and to describe the disorders of calcium reabsorption in the kidney. So to begin with something that's quite simple, there is a reference range for calcium in blood that's between 2.10 and 2.55 millimole per liter. When it's below, this is hypocalcemia, and when it is above, this is hypocalcemia. This range is for a population. If we consider not a population, but an individual, for example, an individual with a reference range for calcium at 2.40, the reference range for this individual will be more narrow, because in a normal individual, blood calcium never deviates from the reference value more than 2%. So it's very accurately controlled. And the mechanism behind this control is that the amount of calcium that's excreted in urine, shown by the blue curve, is matched at any time, but by the amount of calcium that enters the extracellular fluid. So in that case, the amount that exits extracellular fluid is matched by the amount of calcium that enters extracellular fluid. And this is controlled by parathyroid hormone. When blood calcium deviates from the reference value, for example, when it goes below, more PTH is secreted, it acts on bone and promotes calcium bone release, and it acts on the tubular calcium reabsorption and increases tubular calcium reabsorption. And the combination of both is able to normalize blood calcium toward the normal value. If we consider something that decreases the ability of the renal tubule to reabsorb calcium, more calcium will be expected in urine, and blood calcium goes down. But if there is a mitigation or adaptation, for example, if bone calcium release increases, the decrease in calcium will be very limited at the expense of more PTH being secreted, and the patient is able to remain in the normal range of the calcium value. If there is no mitigation, for example, because it's not possible to secrete more PTH, and bone calcium release will not be increased, hypocalcemia ensures. My second question is, what is the definition of hypercalciuria in adult? Is it more than 6.25 millimole per day for women and more than 7 6.5 millimole per day in men? Is it more than 10 millimoles per day for both women and men? Or is it more than 5 millimole per day for women and more than 6 millimole per day for man?
Okay, the poll is open again, so please vote. Okay,
So another
Stefania.
5 seconds. Yeah, I will close.
Thank you.
So it's very close. And actually, the right answer is the first one. It has been determined years ago, mainly by British investigators, and it is still considered at the upper limit of normal 6.25 millimole per day for a woman and 7.5 millimole per day for a man. My third question and last, and then I will not ask more questions. On steady state, a high value of 24-hour urinary calcium excretion tells you that renal tubular calcium reabsorption is lower than normal, or does it tell you that more calcium is entering the extracellular fluid from bone and or intestine?
So I close in 10 seconds.
And the correct answer is B. It tells you that more calcium is entering the extracellular fluid from bone. It tells you almost nothing about the ability of the renal tubule to reabsorb calcium, and I will show you on the next slide. So what I just commented, it was not just theory. Years ago, Christopher Nordin studied the ability of the renal tubule to reabsorb calcium under various conditions. One condition is primary hyperparathyroidism, one condition is hypoparathyroidism, and one condition is osteomalacia due to vitamin D deficiency. The solid curve in black is the represents the behavior of normal population. And this is the normal range for urinary calcium excretion, and this is the normal range for blood calcium concentration. Patients with primary hyperparathyroidism are shifted to the right. And this tells you that they have more calcium reabsorbed along the renal tubule. But you see that their urinary calcium is above the normal range. And despite having more calcium in urine, they also have an increase in renal tubular calcium reabsorption. And the reason why they are hypocalciuric is that more calcium is entering the extracellular fluid because they absorb more calcium in the gut and they release more calcium from bone. Patients with hypoparathyroidism have hypocalcemia and a normal amount of calcium in urine, but they still have a decrease in the ability of the renal tubule to reabsorb calcium. This is why they are shifted to the left. And actually, this is the main reason why they are hypocalcemic. If you now consider patients with osteomalacia, they are equally hypocalcemic, but they have much less calcium in urine. Virtually no calcium can be measured in urine, despite similar hypocalcemia. And what's different in between both conditions? Patients with osteomalacia have a lot of PTH, and patients with hypoparathyroidism have no PTH. And from this, you can consider that PTH is a factor that stimulates calcium reabsorption along the renal tubule. Actually, the PTH receptor is present along the renal tubule. It is expressed in the same segment as the sodium chloride cotransporter NCC here. It is present in the same segment as the sodium calcium exchanger NCX1 in the connecting tubule. It is expressed in the same segment as uromodulin in the thick ascending limb of the loop of Henle, and it is also expressed in the proximal tubule together with aquaporin 1. And actually, PTH receptor is expressed in the very same tubular segments that are involved in calcium reabsorption. If you consider this cartoon, you can see that about 2/3 of filtered calcium are reabsorbed in the proximal tubule. About 25% is reabsorbed in the thick ascending limb of the loop of Henle, and the remainder is reabsorbed in the distal convoluted and connecting tubule. Calcium reabsorption in the proximal tubule and in the thick ascending limb is mostly or exclusively paracellular. I mean, it occurs between the cell. In the distal convoluted tubule and in the collecting tubule, it is a transcellular reabsorption, so it has to cross the apical membrane and the basolateral membrane. The model of calcium reabsorption in the proximal tubule is that the reabsorption of sodium and water concentrates calcium in the lumen and creates a concentration difference that promotes calcium reabsorption across the paracellular pathway. But the paracellular pathway has also to be permeable to calcium, and it is permeable because one claudin, a specific protein of the tight junction expressed in the proximal tubule, claudin 2, is expressed and gives the paracellular pathway a specific permeability to calcium. In the thick ascending limb, calcium reabsorption is also paracellular. The driver of calcium reabsorption is the lumen positive transepithelial voltage that's created by sodium chloride reabsorption. This is a little bit complex, but sodium chloride reabsorption occurs via this cotransporter, and then most of potassium is secreted back in the lumen, and most of chloride is secreted in the interstitium by this channel. And the back diffusion of potassium hyperpolarizes the apical membrane, and the diffusion of chloride depolarizes the basolateral membrane. And because both membranes have not the same voltage, the transepithelial voltage is oriented lumen positive. And this creates, or this causes calcium reabsorption. But again, the paracellular pathway has to be permeable to calcium to allow the diffusion of calcium along the paracellular pathway, and this is due to the expression in the thick ascending limb of claudin 16 and claudin 19, two distinct claudins, not the same as that expressed in the proximal tubule. The dependency of calcium reabsorption in the thick ascending limb to the transepithelial voltage has been shown years ago by James Bordeaux and Maurice Berg on isolated perfused tubule, and you can appreciate that there is an almost linear relationship between the transepithelial voltage and the amount of calcium that's reabsorbed across the epithelium of these tubular segments. The elucidation of the molecular mechanism of paracellular permeability is much more recent, with the discovery of the paracellular protein named claudins. And claudins are expressed in all tight junctions, but depending on the epithelium, the type of claudin that are expressed differ and give distinct permeabilities of the paracellular pathway of distinct epithelium. All claudins look the same. They are small proteins with N-terminus and carboxy-terminus into the cell, 4 transmembrane segments, and 2 extracellular loops. And we believe that the specific property given by a specific claudin is dependent on the amino acid sequence of the first loop. So if we look at the expression of claudins along the renal tubule, we appreciate that different segments express different claudins. For example, the proximal tubule, as already mentioned, expresses claudin 2, and the thick ascending limb expresses claudin 16 and claudin 19 that are mandatory for normal paracellular permeability. It also expresses claudin 10 and claudin 14, and I'll be back to this in a minute. If claudin 16 is removed from the tight junction and calcium absorption is measured or magnesium absorption is measured, you can see that much less calcium and much less magnesium are reabsorbed when claudin 16 is lacking. And this is because the permeability of the paracellular pathway to calcium and magnesium is much lower when claudin 16 is missing. Another property of the thick ascending limb is that it expresses the calcium sensing receptor. It's not only expressed in the parathyroid glands, but also it's highly expressed in the kidney and especially in the thick ascending limb, as shown on this slide. The expression of the calcium sensing receptor can be detected in the thick ascending limb with a very high expression, and the co-localization with uromodulin can be appreciated on this picture. About 10 years ago, we were able to measure the function of the calcium sensing receptor in the thick ascending limb, and we were able to show using isolated perfused thick ascending limb that inhibitors of the calcium sensing receptor are responsible for higher calcium reabsorption. So when the calcium sensing receptor is inhibited, more calcium is reabsorbed, but there is no difference in sodium and chloride reabsorption. There's nothing on sodium and chloride, and it does almost nothing on transepithelial voltage, but it does something on the paracellular pathway permeability. So the calcium sensing receptor is an inhibitor of the, it decreases the paracellular pathway permeability, and antagonists of the calcium sensing receptor increases the permeability as expected. One explanation is that in this tight junction, claudin 16 is expressed, claudin 19 is expressed, and when claudin 16 and claudin 19 are expressed at the same time, the epithelium is very cation permeable. When claudin 14 is expressed together with 16 and 19, the permeability to cation decreases. And one explanation, to make a very a long story very short, is that activity in the calcium sensing receptor increases the expression of claudin 14 that inhibits the property of claudin 16 and claudin 19, and then the ability of this epithelium to reabsorb calcium. The translation of this fact in human medicine can be seen when you consider patients with mutation, inactivating mutation of the calcium sensing receptor that cause disease called familial hypocalciuric hypocalcemia. And if you compare with controls, patients with this disease have hypocalcemia, but they have a very similar urinary calcium excretion despite having as hypercalcemia. And again, from this, you cannot decide that more calcium is reabsorbed in those patients along the renal tubule because they have the same amount of calcium in urine. But if you consider that they have the same amount of calcium in urine, despite having hypercalcemia and then a higher filtered load, then you understand that the same amount of calcium in urine, when more calcium is filtered, means that more calcium is reabsorbed along the renal tubule. So again, it's very difficult to say something just on the amount of calcium in urine regarding the ability of the renal tubule to reabsorb calcium. The last part that reabsorb calcium is the distal convoluted connecting tubule, and then calcium is transcellular. Calcium enters the cell across this channel called TRPV5. It shuttles from the apical membrane to the basolateral membrane because it binds to this intracellular protein named calcium binding protein, and then it exits the cell across the basolateral membrane by this exchanger, sodium calcium exchanger, or by the calcium ATPase PMCA4. So calcium is reabsorbed mostly in the proximal tubule. A significant amount is reabsorbed in the thick limb and in the distal convoluted and connecting tubule. But if we want to understand what controls blood calcium and calcium reabsorption in normal life, we have to consider the factors that increase or decrease calcium reabsorption. Factors that can increase calcium reabsorption along the renal tubule are parathyroid hormone, obviously, the parathyroid hormone related protein, and the active vitamin D. Calcium sensing I'm sorry, calcium sensing activators decrease calcium reabsorption. It should be in the right. Metabolic alkalosis increases calcium reabsorption, decreased extracellular fluid volume, and thiazide diuretics also increase calcium reabsorption. What decrease calcium reabsorption are calcium sensing receptor antagonists. So it should be, it should be on the left. Depletion in magnesium, metabolic acidosis, increased extracellular fluid volume, and loop diuretics. The last part will be to consider. I've done something. Oh, the causes of clinically significant disturbances in calcium reabsorption, and they can be extrinsic or intrinsic. If we start with extrinsic causes, calcium reabsorption can be increased in all conditions of hyperparathyroidism, in conditions of primary excess in 1,25-dioxyvitamin D, under condition of calcium sensing receptor inactivation, for example, in patients with familial hypocalciuric hypocalcemia. It can be and again, I'm sorry, but too much salt and too much meat should be in decreased. Calcium reabsorption can be decreased in patients with hypoparathyroidism or resistance to PTH, according to what PTH does on the renal tubule, and when calcium sensing receptor is activated. And it also in patients eating too much salt and eating too much milk. I would just like to elaborate a little bit on this. A long time ago, Jack Lehman showed that there is a linear relationship between urinary sodium excretion that reflects the amount of sodium that's eaten and urinary calcium in urine, and this is a positive relationship. It means that when more salt is eaten, more calcium is excreted in urine. And one explanation could be that a high sodium intake increases extracellular fluid volume and decreases proximal sodium and calcium absorption, leading to more calcium being excreted in urine. And actually, almost 20 years ago, Tom Nijgenhuis and collaborators in Nijmegen measured that when mice are treated by thiazides and have a lower extracellular volume because of diuretic, they have less calcium in urine and they are able to absorb more sodium and more fluid and also more calcium along the proximal tubule. So one explanation for the ability of thiazide diuretics to reduce urinary calcium excretion is to promote more calcium reabsorption in the proximal tubule. High dietary protein also increases urinary calcium excretion. The same author showed that there is a linear relationship between dietary protein intake and urinary calcium excretion. One explanation could be that animal proteins produces metabolic acids, fixed acids, that has to be excreted in urine. A higher acid load increases bone resorption, but also decreases the ability of the renal tubule to reabsorb calcium, and this leads to hypocalciuria. And this is why patients with hypercalciuria and stone disease are instructed to decrease their amount of dietary protein and their amount of sodium salt every day. If we move to intrinsic causes of disturbances in calcium reabsorption, again, calcium reabsorption can be increased or it can be decreased. It is increased in the thick ascending limb in patients with Helix syndrome. It is increased in the distal convoluted tubule in patients with Gitelman syndrome. It is decreased in the proximal tubule in patients with Wasson syndrome, and it is decreased in the thick ascending limb in patients with Bartter syndrome and familial hypomagnesemia with hypocalciuria and nephrocalcinosis. And I will go into a little bit more details just now. I told you that Claudin 2 is important for calcium reabsorption in the proximal tubule because it allows calcium to flow along the paracellular pathway. And actually, Claudin 2 deficient mice are hypercalciuric. They are in red compared to mice in blue who are normal mice. And this is true on the controlled diet. And this is also true on a low calcium diet. Obviously, your renal calcium is lower on a low calcium diet, but it's still higher than in controls. Fractional expression of calcium is higher. Blood calcium is perfectly normal. So they are hypercalciuric, but they have no hypocalcemia. And patients with Claudin 2 deficiency also have the same picture, that is hypercalciuria with normal blood. Unexpectedly, those patients are very rare. And one explanation could be that the same mutation is Claudin 2 cause azoospermia, and Claudin 2 gene is expressed on the X chromosome. So affected patients are males, and they have azoospermia, which is not the ideal situation to have offsprings. Bartter syndrome causes a defect in sodium chloride reabsorption in the thick ascending limb because of mutation in the gene encoding this transporter, NKCC2, or this potassium channel, or this chloride channel, or a subunit of this channel named Bartin. In all instances, the decrease in sodium chloride reabsorption decreases the voltage, which is the driving force for calcium reabsorption along the paracellular pathway. And actually, patients with Bartter syndrome are often hypercalciuric because of decreased calcium reabsorption here. Familial hypomagnesemia with hypercalciuria and nephrocalcinosis is due to pathogenic variants in Claudin 16 or Claudin 19, the two Claudins that are co-expressed at the tight junction in the thick ascending limb, and one is deficient. The permeability of the paracellular pathway is down, and less calcium and less magnesium also can be reabsorbed. Autosomal dominant hypocalcemia is due to activating mutation of the calcium sensing receptor, Familial hypocalciuric hypercalcemia are most often due to inactivating mutation of the calcium sensing receptor. So both mutations have opposite effect on the calcium sensing receptor and then opposing effect on the ability of the thick ascending limb to reabsorb calcium. It is increased in patients with familial hypocalciuric hypercalcemia, and it is decreased in patients with autosomal dominant hypocalcemia. Helix syndrome is a very rare disease due to Claudin 10 mutation in the thick ascending limb. Claudin 10 is important not directly for calcium reabsorption, but for sodium reabsorption. And it allows part of sodium that's reabsorbed in the thick ascending limb to move along the paracellular pathway. When Claudin 10 is deficient, less sodium can be reabsorbed, and the voltage increases, which drives more calcium and probably more magnesium along the paracellular pathway. Those patients have low calcium excretion in urine. And just to end with my talk, I would like to mention the most common condition probably of hypercalciuria, which is called idiopathic hypocalciuria. So idiopathic hypercalciuria is a condition that affects, let's say, 5, 6, maybe 7% of individuals worldwide. And it is the most common abnormality encountered in patients with calcium stone disease. And it is due to an association of disorders in calcium reabsorption along the renal tubule, of increased calcium release from bone that occurs especially on a low calcium diet, and increased intestinal calcium absorption. Besides this, the molecular mechanism behind idiopathic hypercalciuria remain, from what I know, very mysterious. So just to conclude and summarize, the adequate renal calcium handling is mandatory to maintain extracellular calcium homeostasis. On steady state, urinary calcium excretion does not tell you how much calcium is reabsorbed along the renal tubule, but how much calcium enters the extracellular fluid. And disorders of renal calcium handling are very common. They can be extrinsic or intrinsic. And we know more and more specific causes, but for the most common cause of hypercalciuria, I should say that we still ignore what are the molecular mechanisms that are underlying these disorders. And thank you for your attention, and I will be very pleased to try to answer your questions.
Thank you very much, Pascal. This was really wonderful, and thank you for explaining rather difficult pathophysiology in such a comprehensive way. So we have some questions. I will read them for you, and then please answer. So the first question is whether calcium and magnesium are always coupled in patients with Claudin mutations, or they are not associated.
So if you refer to Claudin 16 and Claudin 19, they both are affected at the same time. But the intensity of the disorder in calcium and magnesium transport might not be the same, but both are decreased. This is the simple answer. Both are decreased. And actually, this explains why patients hypomagnesemia very commonly, and while they have hypocalciuria and sometimes hypocalcemia.
Okay.
If we move to Claudin 2, the role of Claudin 2 regarding magnesium absorption is not clear so far.
Okay, so that's true for Claudin 16 and 19, but not for Claudin 2, I think, yeah?
It might be for Claudin 2, I don't know.
You don't know. Okay, perfect. Yeah, so another question. Yeah, there are quite some questions, so be prepared. So, so the other question is about the use of calcium mimetics in patients with calcium stones. Can you comment on that?
Calcium mimetic in patients with calcium stones. Why would you use calcium mimetics in patients with calcium stones? So calcium mimetic will decrease the ability of the renal tubule to reabsorb calcium, and if they do something, they will increase calcium excretion in urine. So it's not quite appropriate to use calcium mimetics in patients with calcium stones.
Yeah, I think
I would be very reluctant to do this. So one condition could be a patient with primary hyperparathyroidism with hypercalcemia and calcium stones, and this patient cannot be treated by surgery. Actually, calcium mimetic would be useful to normalize blood calcium, but just normalizing blood calcium might not be the goal in a patient with primary hyperparathyroidism, because in most cases, hypocalcemia is very well tolerated. So giving a calcium mimetic that can aggravate stone disease to correct blood calcium concentration, I would be very reluctant.
Okay, thank you. So you just disrecommend it. I think this very important. Okay, so another question is also on the pathophysiology, so about the control of interstitial calcium reabsorption, whether it's controlled by PTH only or also by vitamin D and calcium diet load, I think.
So there are experimental evidence that the vitamin D controls calcium reabsorption along the renal tubule, probably not in the proximal tubule, but PTH does not reabsorb calcium in the proximal tubule also. It's more a distal effect. And when we look carefully at patients who are treated with active vitamin D analogs, for example, patients with hypoparathyroidism, there is evidence that vitamin D, active vitamin D analogs do something on the renal tubular reabsorption, and this participates to the more or less control of blood calcium in those patients. So active vitamin D does something, yes. And what was the other part of the question?
And the other part was actually on the intestinal control of calcium reabsorption.
Testosterone?
Yeah, no, in the gut, in the intestinal control, sorry.
Oh, intestinal. Yes, in that case, there is a lot of evidence that active vitamin D is a main determinant of calcium absorption in the gut.
Yeah, sure. So I think you answered very clear, but the intestinal, the gut is vitamin D, actually mostly vitamin D controlled, right? Okay, so I'm trying to select the questions because a lot of people thank you, by the way. So I think it was really wonderful lecture. So this is very good to hear.
Thank you.
So,
I'm sorry for the mistakes between columns. I will send a corrected version of my presentation.
no, you know, somehow you comfort a lot of people because I mean, calcium metabolism is very, very complicated. So when the expert like you is sometimes confused, it gives a lot of comfort to the audience. But I think it will be good indeed that the correct version is published on the website. So that's so. But I'm going on with the questions. We still have 10 minutes. So there are some difficult questions and not so. So why with the high PTH levels patients with kidney disease get vascular calcification? That's it's a broad subject.
Yes, it's a question for vessel physiologist.
Yeah.
I'm not sure.
Yeah, I think it's a broad subject with the tree and a lot of things going on there. So maybe it should be a separate topic, maybe for a different webinar. Maybe we go back to our calcium physiology, and there's a question linked to the previous one. Do you know diseases?
If I may, I would say that patients with primary hyperparathyroidism and normal renal function may have vascular calcification, but this is not such an issue as in patients with CKD and decreased GFR and secondary hyperparathyroidism. And those conditions are very different. And probably the pathophysiology of vascular calcification in patients with CKD and hyperparathyroidism, mostly secondary, is something very different from what can happen in patients with normal renal function and primary hyperparathyroidism.
Okay. Another question is regarding the diseases that cause decreased calcium reabsorption in the gut.
Mm-hmm. But what is the question?
What is the question? Yeah, I just mentioned the diseases where calcium reabsorption in the gut is decreased.
So there are many conditions that can alter the ability of the gut to reabsorb calcium, and vitamin D deficiency, for example, is one condition. Calcium is mostly reabsorbed in the duodenum and in the jejunum. And conditions that are associated with removal of or functional removal of the duodenum and jejunum. For example, celiac disease are associated with a defect in calcium reabsorption. Surgery, bariatric surgery is associated with a decrease in calcium absorption. All conditions leading to lipid malabsorption cause calcium malabsorption because lipids and calcium bind to form a complex that cannot be absorbed. So there are many conditions that can cause calcium malabsorption. along the gut. The list is very long, actually.
Okay. Very good. So another question is again more about pathophysiology and about the PTH level in patients with autosomal dominant hypocalcemia, whether it's increased or decreased.
So typically, it's in the lower range of normal or slightly lower than normal. Because the activation of the calcium sensing receptor decreases PTH secretion by the parathyroid glands. So typically, as in the clinical example at the beginning of the presentation, PTH is slightly below or in the lower range of normal.
Yeah, that was indeed the example you showed in the first slide, I think. That interesting question is about the effect of SGLT2 or inhibitors on calcium excretion.
So what can be what one effect of SGLT2 inhibitors would be to decrease calcium absorption in the proximal tubule, because it does something on sodium absorption, and indirectly sodium and calcium absorption are linked in the proximal tubule. But at the same time, SGLT2 inhibitors tend to decrease extracellular fluid volume, which has the opposite effect. So it's kind of balance between both effects, one that decreases and one that promotes calcium absorption in the proximal tubule. And the result in one given patient can be different from another patient. So I would say you have to check. For example, if you want to use a SGLT2 inhibitor in a patient with calcium stones, you have to check what it does on calcium excretion.
Yeah, I agree. I'm scrolling through the questions. There are some questions regarding some specific clinical courses. I think it will be difficult and there are not so many details. So people who have some specific questions, maybe Pascal, if they can contact you with some specific, because I think it will be very difficult to discuss it via the webinar platform. So once again, I think there are a lot of people who thank you for this very good lecture and for explaining this difficult subject in such a comprehensive way. So I think we can stop here. And then especially would like to thank you and also Stephanie, because both of you are on vacation, which is very nice that you spend your vacation time doing this lecture. Okay. And so thank you very much. I think we can close the webinar.
Thank you very much.
Thank you and have a nice afternoon.
Bye-bye. Bye-bye, everybody. Have a good day. Bye.